Hi, my name's Sara Trompeter. I'm one of the consultants at NHS Blood and Transplant, and I have the privilege of being involved a lot in the treatments and support of transfusion in patients with sickle cell disease. We're just going to wait a couple more minutes, or maybe a minute or so more, to see who else joins us. So if you can just bear with us, and then I'll introduce our amazing panel, and then we can talk a little bit more about their experience, which we're very grateful they're going to be sharing with you. So we'll kick off probably at about 12:04. Good afternoon, everyone, and welcome to our webinar. My name's Sara Trompeter. I have the privilege of being a consultant looking after patients with sickle cell disease, and I work at UCLH and NHS Blood and Transplant, so some people on this call will know me. We are very privileged today to have a wonderful panel of patient experts brought together with our friend Petra from the Sickle Cell React Equal Awareness Movement, SCREAM. And we're going to kick off by asking her to introduce her team, her panel, and then what we're going to do is ask people about their experiences, this being Disability Awareness Month, of having sickle cell that might help you in your jobs and just generally help your understanding of the condition that I know so many of you are helping in different ways our patient cohort. So over to you, Petra.
Thank you so much, and thank you for inviting us. So I'm Petra, I'm from Sickle Cell Reach Equal Awareness Movement. I myself have sickle cell SS, but just to introduce the panels, the panelists that are here today, we've got Sana. Sana is the first person in the Northwest of Asian descent to be diagnosed with SD. She also has her own blog where she talks about sickle cell and her experience living with it. We have Jodie here, mother of 3. Jodie lives with sickle cell beta thalassemia, and she lives in Surrey. She has her 6 weekly blood exchanges. So excited to hear from her as well. We also have Manny. Manny has SS. He runs an organisation called Once. We Are Not the Same. You can find them at Once UK on Instagram. And we have Ali, also known as A-Star. He works closely in the community on various projects, his most recent being Hidden Pain, and he's worked with NHSBT in the past, so you might know him as well. But they'll go through their personal diagnosis individually.
Thank you, Petra. That's a really useful introduction. And so what I'd like to do is kick off by asking some questions that I hope everyone else will find enlightening and informative. We obviously have a chat going, so feel free to ask questions, and I will be able to pick some of those out as we go. I think there's quite a lot of people on this call already. I don't think we'll be able to answer everything, but let's get things started. So Question number 1. How does being on a regular transfusion regimen affect your quality of life? Who'd like to answer that one?
I guess I'll
for
go
it,
on that one. Morning or afternoon, everybody. So yeah, I'll dive straight in. I think personally, it's been a dramatic effect on my quality of life. The reason I began with the red cell exchange program is because my admissions into hospital became so bad that I was given an option of either hydroxycarbamide or red cell exchange transfusions, and I opted for the transfusions. Prior to my transfusions, in a 24-month period, I was admitted into hospital 21 times. And so for me, the quality of life has dramatically improved. I think I can safely say in the 3 years that I've been on the program, I don't think I've been admitted as many times as I was within the 24 months that were before that. So it's definitely turned things around for me a lot.
What does that mean in practical sense? What does that mean in terms of work or relationships? What are you able to do now that you weren't able to do before?
It's not so much there's a level of what you can and can't do, because you definitely get used to the pain. For me, I'm less lethargic. I'm definitely feeling the background pain a lot less. And that's where you see the real benefits. And, you just tend to have a little bit more energy where it's needed to get through the day. So for me, those are where I feel the benefits more. In terms of work, it means that, there are not as many absences through sickness and hospital admission. And with relationships, it's a difficult balance, because whilst you're not being admitted into hospital at the same time, for me, every 5 weeks, I have to go to hospital for my actual transfusion and for my blood match as well. So there's definitely pros and cons to it, but overall quality of life dramatically has improved.
That's a really great answer, great informative, and really helps us understand what the impact of transfusion can be for some people, which in your case is less hospital attendances, although you quite rightly say about how that it is definitely a commitment. Nevertheless, you do have to spend some time in hospital, but I suppose it's scheduled time, so you know when you're coming, so you can tell your employer, and it's not necessarily associated with that desperate pain that you've experienced in the past. Although what you very interesting talked about was the pain that remains, and those people who've been in significant pain over long periods of time often have that chronic pain feature of sickle, which is extremely uncomfortable and difficult to bear and still impacts. But away from the acute crisis probably does allow you to interact with your life in a lot more healthier way, I guess, and a lot more pleasurable way. That's great. Does anyone else want to talk about their experiences on the long-term transfusion program?
Yep, I have. I was married in 2017, and after 20 plus years of being on hydroxycarbamide, I was told by my doctor that it could be it can affect my reproductive system, which I didn't know until I got married and my doctor spoke to me about it. So my wife and I decided for me to come off hydroxycarbamide. And when I came off, I was having back-to-back crises. My body wasn't liking it at all. So this was in the month of April 2018. I'd been married for a year and a bit. Oh, no, actually nearly a year. And so for a good 6 months, I was having back-to-back crises. And around October 2018, they said my doctors suggested that I get exchange transfusions as well, every 6 weeks, up to 11 units. And since October or November 2018 up until now, I've had no crisis whatsoever because of having these exchange transfusions.
That's amazing. And what has that allowed you to do which you weren't able to do before, or allow you to do more of?
Yeah, so obviously just concentrate on family and everyday life. You know, we've got a seven-week-old child now,
Oh
a
my
daughter.
goodness, you need energy for that.
Exactly.
Everyone needs a blood transfusion for a 7-week-old.
Exactly. So it's helping me to concentrate on my family, do things that I need to do at home, especially with obviously lockdown that we've had. I've been able to look after, you know, my pregnant wife at the time, and just concentrate on home, which
So
has been
that's allowed
great.
you to be in a more caring role rather than be cared for, which must be a
Exactly.
nice dynamic.
Yeah, and on top of that,
Shift.
you know, I'm having to go every 6 weeks for my transfusion. So yes, I will be tired and out for a good 2 days around my transfusion, but after that, I'm able to get back on my feet and get on with things.
That's lovely, and congratulations
Thank you.
to the new daddy. And talking about babies, Jodie, did you want to talk about any experience of transfusion and pregnancy? Is that something that you think you can inform people about a bit?
Yeah, definitely. So I started on the blood exchange program when I was actually 7 years old, because I had 2 strokes, and so I've been on it now for 16, coming up to 17 years, and I can honestly say it's completely changed my life. I know that I don't really know much of my life before that, but I know that before I started on the exchange program, I was in hospital quite a lot as a child, and even prior to going to have the apheresis treatments and having it manually, because that's how it used to be done, it didn't keep me as well as what the apheresis does. So I have so I have 3 children, and I mean, all of my pregnancies have been pretty plain sailing. I've managed to have my exchanges all the way through having the pregnancies and being pregnant, and yeah, it's all been absolutely fine. So yeah, I've been so grateful that I've been still being able to have my exchanges through that.
So you're healthy enough to be bringing up 3 children, is what you're saying?
Yes, definitely.
And the other thing you touched on that we didn't say we were going to talk about, but it's interesting because we're all adults here, but you're talking the impact of having uncontrolled sickle in childhood means not going to school, really, and not going to school impacts on your ability to earn, to attain later in life. And we probably don't think about that enough. And I think in the old days, there was not much expectation based on the potential achievements of patients with sickle cell disease, so no one seemed to care terribly much. They weren't in school half the time. Whereas I think our focus very much has changed now, that, you know, if I see that they're under 95%, then I'm worried that we're under managing. So it's interesting that you talked about your childhood there and how much uncontrolled sickle would have impacted you in school. So that's really interesting.
Yeah, my attendance was not ideal at school. I definitely didn't get the grades. But I managed to, I went to college and I qualified as a beauty therapist. But to be honest, I don't work as a beauty therapist anymore, just because of with sickle, it takes a lot of energy to be a beauty therapist. You're on your feet all day, and it didn't really suit my lifestyle. But I still do beauty stuff, but within my limits. So but I haven't
that's what we all do as parents. No, but I think that's what we all do as parents. I mean, and as you grow as a person, whatever your circumstances are, that you have to adjust to what your new reality is. That's really, really helpful. So we've talked a bit about the benefits that some people have experienced when they're on regular transfusion, but we do know that some people have very difficult to transfuse blood. And I wondered if any of you are in that situation and whether you'd like to discuss the impact of that and what happens if you get sick and what kind of discussions happen there.
So I can sort of pick up on this one. So I've got SD disorder. So my strain is from Punjab, so sickle cell Punjab. And as a child, I was in and out of hospital. Obviously, I'm on prophylactic penicillin and folic acid. And then if I had a crisis as a child, it'd be going in and being treated with opiates. And I would have blood transfusions, but not often. When I hit 18, I had acute chest syndrome and had a red cell exchange then. So I was having the units of blood. And after that, I developed antibodies. So I started to react really badly to blood. So I've got antibodies, I think S and F. So since 18, they put me on hydroxycarbamide because I wasn't able to transfuse anymore. And then I've been told from haematologists that they would only give me blood in case of an emergency. So if it was a car accident or pregnancy or anything like that. So I've been really, really cautious about managing my lifestyle and managing sort of my crisis. So I still have quite frequent crisis with hydroxycarbamide. I still get really tired, still get pain. I'm still admitted in quite a few times in the year. And even when I am admitted in, it's a long process to get better because they can't give me any blood. Last year, I again developed acute chest syndrome, which turned into pneumonia. And then I was rushed into ICU where they gave me another red cell exchange. So I was under the impression that I couldn't have any, but then I was told, well, it's an emergency and we're going to have to transfuse you. And I had conversations going back and forth with doctors being like, I don't want to have blood right now because in case I am pregnant or it is life and death, what am I going to do? I'm going to be stuck in the future. And it was really difficult conversations because obviously the more blood I have, the less likely I am to be able to have it in the future. So anyway, I was transfused late last year with blood. They stopped the red cell exchange halfway through, trying to measure how much was safe to give me and how much wasn't. And then what happened was the line that they left in with the transfusion in my leg, the femoral line, they left it in too long because there was no one qualified to remove the line. And then that developed into a DVT. So it's just been so many complications in and around having transfusions and blood. But for my experience with blood transfusions, I'm not moving forward. I can't really have any more. And when it comes to pregnancies and wanting to fall pregnant or have a baby, I will have to come off the hydroxy, and it's about balancing that between what is safe, what's a safe sort of plan moving forward. So that's again another difficult conversation that will be had in the future.
So obviously very difficult times for you and distressing, and then having to have very difficult and complex conversations about risk when you're presumably feeling absolutely dreadful and frightened because you're ill anyhow. Sounds like a really complex situation. One of the things you brought up there, which I think would be useful for further discussion, is about venous access. So I think we'll probably have members of the therapeutic apheresis team on this webinar who are regularly administering red cell exchanges to patients with sickle cell disease, as well as other therapeutic apheresis procedures. And one of the difficulties we have is finding really good veins to perform these procedures. And you talked about having to have a central line, and for those who don't know, that's when you put a great big tube, I've had this done to me and it's horrible, in your groin or your neck. They do it under local anaesthetic, but having had one, that seems like pulling out all your teeth with one injection. It was truly unpleasant from my experience. It has its associated risks. It's unpleasant, but it also has its associated risks. And I wonder if any of the rest of you have had experience of other ways of accessing your veins so that you can get the treatment you need that is less invasive. And if you could tell us a bit more about that.
Well, I used to actually have it in my arms when I first started it, but my veins were too weak. My transfusions kept getting cut short. Until they told me femoral line is the best way. But femoral line also has its dangers as well. I had a time where, because I get it every 6 weeks, I try my best to swap sides. But we had a time where we did it twice in a row on the same side, which was the right side. And eventually, I usually have 11 units. We had to cut out 5 because there was scarring in the groin area.
So you weren't getting the full treatment.
Exactly. So the flow wasn't good. The machines were ringing off, and they said eventually we had to stop because there's scarring in that side. So that's one of the dangers as well, of not being able to have my full transfusion because of that. So we're having to keep swapping sides from our groin on the left side to the right side.
And that must be quite uncomfortable, and it adds to the time, doesn't it?
It does, yeah.
Because if you're just in your arms, you can get in and out in half a day. But if you're having it in these big lines put in, you're often there for the best part of a day, aren't you?
Yeah, but when I was having it in my arms, because my veins weren't as strong, I was there from 9:30 and I'd leave around 6 o'clock. With
Right.
actually faster for me. The earliest I've left is like 1:30, 2 o'clock. But I try my best to take my time as well, because I've had times where I fainted when leaving the hospital because of the so much blood being taken out as well as blood being given to me. One time I went to a local Tesco and thought I'd get some food before I go home. I usually get a taxi home, and Nando's is just opposite. So I went to Nando's and I was ordering my food and I fainted. Woke up on the floor. So I usually try my best to take my time after my transfusions.
Good advice.
And just take my time and get myself in the taxi and go home.
Great. So what I was trying to bring up, and I don't know if any of you've got this experience, is that more recently, so that we don't have to use these big lines, and because we recognise some people's arm veins are ones that we can see and feel are a little bit ropey, people have been using ultrasound cannulation, so using an ultrasound machine to find the deeper veins in your arm. And I just wondered if any of you had that used. Manny, I think you look like you've unmuted yourself, so I'm guessing it's you.
Yes, definitely. I'm really fortunate to be under an amazing apheresis team who I can't express enough how much their experience has helped me over at St. George's, by the way. It's really beneficial to have a team that are, just so clued up in what they're doing. And for me, when I first started the procedure, I remember, excuse me, I remember it being in 2 separate arms, which it wasn't bad. They made it as comfortable as possible, making sure that you can still bend one arm. However, now I have the procedure in just one arm, so I have 2 needles in one arm, and it just makes for a really pleasant experience. It's very quick. It's less excuse me, less invasive, and it's just an all-round pleasant experience, really.
So I'm on 2 screens and lost my cursor. That is really great advertising for St. George's Hospital. Well done. But it's really good to hear what things go well as what things go wrong. So we're talking about things in this conversation in quite a mechanical way. We're talking about lines going in, blood being available, what treatment, but often it's the softer things that make the bigger differences, or certainly add to the experience. And I just wondered if you had thoughts about what things do doctors and nurses and laboratory staff do right and wrong that impact the actual experience of what is quite a technical process. If any of you would like to speak? Who hasn't spoken before? Who wants to speak, or who wants to speak some more? It's Manny, it's back to you.
It's massively important. Honestly, it makes all the difference. Simple things like being extremely competent and confident in delivering the service that you have to deliver make all the difference, and it gives you, it's one less thing to worry about when you have confidence in the person that is delivering your care. Something specific to us as people living with sickle cell is the vein conversation. It's always, it can go one of 2 ways. You have somebody who will take heed to what you say, or sometimes you have the person who's so sure of themselves that when you say to them, I don't have good veins, or you won't get any blood from there, or the line's not going to stick there, they feel like a sense of they want to kind of prove you wrong, or almost
a bit threatened, perhaps.
Not even threatened, just a sense of wanting to prove that they are that good, almost.
Ever than any other doctor that you've ever seen in 35 years.
Yeah, exactly.
Amazing.
and whilst you understand where they're coming from, it's difficult because you want them to understand where you're coming from, in that you've done this dance like 100 times and exactly how it goes. Yeah, exactly.
And Manny, this is where you end up with like 6 tries on one arm, and it just hasn't worked because they haven't listened to you, innit?
So it's about
that.
listening, isn't it? Because actually you're patient experts. This is not your first rodeo, and listening to patients, I think, is the message of what you're saying for this bit, is that actually we know quite a bit about what we need in our own health and our veins in this case, and actually we need to be listened to, and not listening to us is not helpful.
To add on to what Manny was saying, I find that a lot of staff get really defensive if you say, is there someone available that is able to get the needle in first time? Because I've been in situations where I've been cannulated from head to toe, bruised from head to toe, and it's getting to the point where I've got no veins left and I can't get my treatment. And having the expertise and the skill and the care, because when I've had red cell exchanges, I felt like I've been butchered, especially with the femoral line. People that manually pumping blood in and sucking blood out. It's an awful experience. And then with the result of femoral lines not being removed correctly and the DVT that I had, I'm now on lifelong anticoagulation because I'm high risk blood clot now, and that could have all been avoided if the lines had been taken out properly.
So
you know how nice it is when a nurse listens and actually, like, if you say I've got really bad veins and they warm up your hands and they've just that caring that you know, so if I say to a doctor or a nurse that, you know, I'm difficult to cannulate or anything, I don't want to have to justify it. And if I say that my arm is not appropriate, I know that you think you can feel a vein, but I know that this arm gives me problems, so I don't want to have to argue with you.
So what about the whole thing of and we talk about this with the teenagers about being able to advocate your own health needs, and it's being able to articulate. Now, you are all educated, intelligent, and can speak up for yourself, and yet still you're saying that sometimes even then you're not listened to. And it's extraordinary, isn't it? Because it's not that English is your 10th language and you've never been to a hospital before and you're not very bright. You are intelligent, articulate, vocal, knowledgeable people, and still there are times, not all times, where you're not listened to. So this is really good advocacy, just to say, listen to us. We know what we're talking about. We've done this before. If I'm saying this, listen to me. And I think I've got some health problems, and when I've been in hospital, I never say I'm a doctor because I always think they'll kill me. But they, people don't listen to you. They just don't listen to you, and it's extraordinary. And I just think, I mean, sometimes they do, but they really don't sometimes. And it's an extraordinary experience. It's very, very distressing actually when you feel you're not being listened to. And in your case, you're saying actually physically hurtful and has long-term impact. So that's really a good message to hear from you all. So what do nurses listening to you, what do you think about kindness? Is it important?
I feel like after a while, when you've gone through the ropes several times and you've not been heard time and time again, you almost get trained. It's difficult to break out of it, and it just takes one nurse or doctor to be kind and respond to you as a human being. I myself, I've made mistakes as a patient, as an adult, in the last couple of years, where I've listened to the advice of, for example, my haematology team, and I know my body, and I know that their advice is based on the general knowledge, but I know my body. So instances where, I've been told we're going to give you blood, and I'm thinking, but my HB isn't as low as I know I can go. and they're insisting, no, you have to, it's a safer option. But for me, I know what I can handle, and I know what I need when it comes to transfusion. I know that as a patient, you don't know everything, but you do. I think all of us can say that. And 2 years ago, I made the mistake of settling and saying, okay, I'll have the transfusion, because I was in pain. And how many times can you say no? How many times can you say, let's hold off? You're in there on your own. So yeah, I think that even as an adult, advocating for yourself can be difficult. And just to have that one person to say, actually, let's listen to her, let's see what she needs, as opposed to bombarding her with all of this medication and stuff, can really change the outcome.
Can I just add to what Petra's saying? So I had my last transfusion. I left home on time. Obviously, I don't drive when I have my transfusions, so I always get a taxi there. I left my house on time, and unfortunately there was a car crash on the way to hospital, which made me be late. So I made sure I called in and told them I'm going to be a few minutes late. As soon as I came in, there was a nurse that I hadn't seen before, started having a go at me. You're late. They've been talking to me downstairs because obviously I got to go downstairs to get my femoral line surgically put in. They've been having a go at me. Make sure you're not late again, and blah blah. And that just dampened my whole mood. I'm here at 9:30 in the morning. It's already mentally, has a mental effect on me. Coming here every 6 weeks and having having to go in the surgery room, so waiting downstairs with other people who are going in and coming out of surgery, and having to lay on the bed, get local anesthetic, get a femoral line put in, and then sent back upstairs to go through a whole transfusion. It's mentally challenging as well as it is physically. So the smallest thing we would like is kindness from a nurse. We understand. Sorry that there was an accident. Sorry that you couldn't make it on time. Let's get on to things. But luckily, after that woman, my vibe with her was just off for the whole day. But luckily, I had two great nurses after that came, and I think they kind of heard how I was spoken to and saw my kind of mood. And, they started having great conversations. They asked about your family. How are you? How are you getting home? And things like that. And nurses that you see regularly start, catching up with you. How's the family? How's your baby? Things like that go a long way.
So I think what you're saying is compassion is key, and also understanding you as a person, what's happened to you. So of course, when someone's been late for because of a car accident, surely the question really is, are you all right?
Exactly. And that
you must have been stuck there forever. Yeah. Gosh, thank goodness we've managed to sort out the line for you. Don't worry, just relax, it's all in place. Don't worry.
Yeah.
I don't know if the others have experienced this, but in hospital, when you're communicating to the nurse that my pain is increasing, it might be a 4 out of 10 or 5 out of 10. You're like, I need the morphine, or I need the fentanyl, or I need the drug. I don't feel like I'm heard until I'm screaming in pain, until I'm a 10 out of 10, 11 out of 10. Then do they react? And it's like, oh, you look fine, you're sat there, you're calm, because they can't physically see anything, or they don't understand the nature of the illness. They leave you and leave you and leave you until you're in excruciating pain. And I've been in instances where I've been crying so much, and nurses have told me to be quiet because I'm disturbing other people, or doctors and nurses have said, if I've gone into A&E, they're like, you don't have sickle cell because I'm Asian. Wow. And I'm there in a crisis trying to prove that I've got sickle cell. Like, it's just, there's still such a lack of understanding and awareness of the nature of the condition, whether it comes to the levels of pain or the different races or the variations in sickle cell. So people actually listening to you and being responsive goes such a long way. And I'm in my 30s, I still need my mum with me to fight for me and get me my treatment, because I just don't have the energy. People aren't listening to me. Sometimes it's just a disaster.
Yeah, and I've seen that quite a lot. I think education is key. I think that there's other issues that I think we can come on to about prejudice and interpreting pain in ethnic groups that aren't your own, and differences between how staff see patients, which we probably should go on to as well. But the other thing that I find very characteristic of sickle cell pain from an outside perspective, obviously because I don't have sickle, but is the lack of movement. It's really quite different when you're looking after a patient. So when you've got a woman in labour, they're like flapping around all over the place and moving and lots of noise. And often our patients with sickle are very, very quiet and don't move. And I think that is not people's expectation of what pain looks like. So I was on the ward the other day and looked after a small child, and they said she's fine. And I looked at her, and this was a toddler not moving. Now, toddlers don't not move. They move they're like everywhere. They're like cats, just you can't even get hold of them. And she's sitting on a bed, and she's just sitting there. And I said, how long has she been sitting there? Hours. I said, well, she's in pain there, she can't speak yet. And it's, sometimes we have to advocate for our patients because they can't actually speak yet, but it's just that lack of understanding and being able to see it through their eyes. But what you raise is an issue that is really, really important, is belief and understanding what another person looks like in pain. And there's been quite a bit of work on this, is about how if you're most of the comparisons have been done from people of African descent compared to people of European descent, and what pain relief they get when they present with the same symptoms of pain, and there's a massive disparity. And I wondered what your thoughts about this were, and what should be done to address it, apart from be furious, which obviously we should be, but what would be constructive and what would be helpful, and how can we adjust that disordered thinking and that prejudice?
I feel like it would be massively important to actually listen to patients. You can't stress that enough, because when we come to A&E, it's a last resort. It's never ever where we want to be, and there's always this reservation of okay, if I have to, and there's a sense of PTSD that comes with that as well, because of previous experiences. I mean, I've been admitted into hospital before, and I've had a doctor tell me that he studied at university for X amount of years, so he's not going to give me fluids, he's not going to give me oxygen. He said I don't need it because sickle cell patients don't need that. And he's told me, you know, and there are certain things that the understanding is not there, I feel, when it comes to being admitted with sickle cell, because we're coming from a place of being at home in excruciating pain, trying to manage the pain with cocodamol and tramadol, and getting to A&E to be offered paracetamol.
Yes, I often say that. I said, I often say this to junior doctors when I'm doing training. I said, you've got a woman in labour, she comes in, she hasn't had any paracetamol or ibuprofen when she's been at home because she knows that's not going to do it. Are you going to offer her paracetamol? And no one does. No one offers a woman in labour, because often I find that you're asked, what have you taken at home? And I feel that if you've had very quick onset of very severe pain, why would you take paracetamol and ibuprofen? That's not going to do anything. You know, you want the proper stuff, which you coming to hospital for. Otherwise, you wouldn't be coming to hospital, because obviously, who wants to be in hospital unless they have to be in hospital? If they're, you know, so you know, saying to sort of berating patients for not going up the analgesic ladder is pointless, and not offering the pain relief that is appropriate for the level of pain they're in. It just seems completely counterintuitive. You wouldn't do this to other patient cohorts. If you'd seen someone in a road traffic accident, you wouldn't ask them to justify their pain. And I realise it's subjective pain. But I think we have to just have that understanding that you've got a woman in labour, you can't see their pain either. You just know for a fact, you always know that really hurts. So, and if someone with sickle, you need to believe the same thing.
The funny thing with that is I've had a very interesting conversation with Jodie about this, about, you know, sickle cell pain versus childbirth. And I think, Jodie, it would be a very appropriate time for you to just comment on that, just so there's a good understanding of, you know, the difference between the two and how you weigh them up.
Yeah, go on, Jodie. That's a really good question. Go on,
so yeah, for me, childbirth was a breeze. I was like, I would take childbirth over any like sickle crisis completely, and because of you can see an end to it. But I do completely agree about the fact that we wouldn't go to A&E unless we were in that amount of pain that we cannot control it at home. Like for me, A&E is the last resort. I've got 3 children at home. I can't, my whole life is turned upside down as soon as I go into hospital. So I completely agree with that. The fact that, you know, I wouldn't be in A&E unless I need that medication. So please, can I have it?
That's something else which you've brought up there, which is the finite nature of certain pains. And when you're in the middle of a crisis, it could go on for days. And although we're supposed to bring your pain under control, in reality, that often doesn't happen as quickly as it should do. And I think with severe pain, and I think that's how a lot of us women manage childbirth, is it's going to be over. There is an end to this. And if it doesn't end soon enough, someone's just going to give me a cesarean anyhow. It is definitely going to end. Whereas with sickle pain, is that expectation of where is this going to end? How many days am I going to feel like this? Right, I can manage for another half an hour, but how can I really manage for hours ahead? And I think And also the feeling of, is the fear, because with babies, you know why you're in pain, you know you're having a beautiful baby, but I think with sickle, you're always got in the back of your mind, am I actually seriously ill? So you've got the added level of actually anxiety generally about your health and where this crisis is taking you. So I think it's, you know, it's you're already upset, you're already anxious for very valid reasons. Then your pain isn't controlled. So now you're in pain, you're anxious, and you know, I think it's a really toxic mix. And I think it's something that you do well to recognise. And every woman says what you say, Jodie, and it always gives me goosebumps, which I've got now, because I just thought, if I'm in that much pain out of the blue when I'm like walking down the street, as I was when I was pushing out my babies, and it could go on for days, and someone was sitting in A&E saying, "You're not in pain, darling," I mean, the thought of someone not believing me would have just. It's just
also the psychological side. I think we're all very passionate people. We've got things that we enjoy, we love, we're talented, we have careers, and then all of a sudden, you know, at a drop of a hat, we have to go in, and you just have to remember that you're seeing us at our worst.
Yes,
We do not want to be there, but we are often not what we are in A&E. We don't look like we normally do. We don't sound like we normally do. You know, I've heard aggressive before, so the aggressive sickle cell patient. Honestly, if you see me screaming in a corridor, you would think it's just this angry lady screaming in the corridor. But there's a lot that comes with that. It's not just the pain. I'm thinking about, okay, I could potentially lose my job. I didn't get to do what I needed to do today. Did I pay my rent? Did I, you know, when you go in, you don't know whether you're going to be in there for a month or longer. So there's a lot that goes with it. It's not just deciding, can I go into A&E? It's also, what are the repercussions of me actually
I think
going?
it's really, really well articulated and hugely important to understand. And yes, none of us are, as a patient, you're not at your best, are you? You're scared. Then you're given very strong painkillers, which help a bit, but not totally. Those painkillers do cross into your brain, and you probably aren't quite your articulate, charming self. I also know that a lot of patients, by the time they come to hospital, haven't slept for a day. So you're exhausted, you're in pain, you're scared, you're not being believed. And it's a very, very toxic combination. Who would be at their best at that point? I think that's asking a bit much of anyone. Well, I'm going to have to round up now. I think we could talk forever, because your advocacy and your speaking of your real lived experiences has been quite extraordinary. And although I know a lot of what you're saying, each time I hear it, it adds something, I think, to the conversation that we all need to understand and appreciate when looking after and understanding and spending time with people with sickle cell disease. So I've found it informative, and I've been doing this for decades now, and I'm really hoping that those on the call also have found it as amazing as I have. And I'm so immensely appreciative for all your time in the middle of a working day that you have. I don't know where you pack your children off to, Jodie, and Alidor, why is yours still quiet, your house there?
She's asleep.
She's asleep downstairs. She's sleeping.
Well done, good parenting. Okay, but I think we could talk about this for ages and ages, and some of your experiences, Petra, Mani, Jodie and Ali, just amazing. So many thanks. I just didn't know if you had any other messages you wanted to, before we do the end of the talk, about what you wanted people from NHSBT to take home after this, if you've got a little message for them. I think there's quite a range of staff here, so people from laboratories, offices, logistics, some nurses, so there's quite a range of people you could shout out to. So off you go, one at a time.
So can I just add, thank you so much for this conversation. I think the first thing that we should get started with is actually having a conversation. Short story, there was a boy during the lockdown times, I think early first lockdown times, who was stopped by the police, and his car was stopped and searched, and he was asked why he was stopped and searched, and you know, there was no there was no good reason. They said that his car looked suspicious, so he understood he was being racially profiled, and he said, I'm going to, you know, I'm a qualified football coach. I've coached some well-known footballers. I'm known in the area, and you should, if you knew the area, you would know that I'm no threat to anyone. And he said to the police officers, I'm going to be in your offices training each and every one of you on how to approach Black people when it comes to stop and search. Months later, I saw it on the news. They invited him into an office full of about 50 police officers, and he was doing a seminar and workshop on how to approach Black people. I think when it comes to the NHS, these are the kind of conversations we need to have. Have these people like us who are going through this in the room, having conversations, so you can listen to their stories as well.
Amazing point. Just to build on that, we're not all drug seekers, and you know, there's a very important transition when we go from A&E to or when we get to A&E, you know, in the time that we are in need of the pain relief. Before we have that first bit of pain relief, that time is the worst. And you know, listening to us and our experience would make the world of difference, is what I would say.
Thank
Yeah,
you,
I was
that's
just
great.
going to pick up on that. I was just 100%. We're just not there just for the drugs. We are there to get better, and we want to get back to our lives. And also, if it wasn't for being able to have our blood exchanges and all the work that goes on behind the scenes of actually having our blood exchange, like, it wouldn't be possible for us to live our lives as normally as possible that we can. So it's appreciated so much.
Thank you. Sana?
For me, like, I'm so grateful for the NHS. They've saved my life. I'm sure they've saved everybody else, like I wouldn't be here. But it's not, we don't go into hospital just for the fun of it, or it's not an isolated event. This is our lifestyle. I've lost jobs because of having to take so much time off because of in a crisis, and it doesn't just end after hospital. It's the recovery, the conversations with employers, not being able to keep up with your peers and your friends, not being where everybody else is because of this illness. And it does have a detrimental effect, not just on your health or on your career, but on your mindset as well, and so much therapy that comes after it. So it's a huge impact on your lifestyle, and you can't tell physically. And I have to find it's just a struggle. Like, I'm not going in with a broken leg. It's not a one admission. It's constant. So I know what's right for me. I know my protocol. I know what works, and just having that clear communication, because I don't want to dread going into hospital. I want to feel like it's the safest place for me, and I'm sure everybody else does. And I think with that communication, that understanding and compassion, it'd be such an easier process for the nurses and the hospital staff and for the patients. But yeah, thank you for this opportunity. It's been amazing speaking to you all.
Petra, the ringleader.
Thank you for this conversation. Thank you to each of you. I feel like it's a very vulnerable thing, you know, talking about your sickle cell. And I myself have struggled with that. So to know that everyone has been really forthcoming and happy to talk about their experiences is really important. And I really hope that we continue to do these things, because it needs to be our voices. There are a lot of people that want to advocate for us, not necessarily in the right way. So I understand that the intention is there, but the way that this is going to work is if we actually use our voices and say what is real, what is true to us, and hopefully we get that message across, changing the stigma. You know, it's about showing who we are. So more of this, please, and thank you.
Thank you very much. Okay, I think we're going to round up now, because we're supposed to finish at 12:45 and we're 12:50, but hopefully we can have you back at some time again, because this has been amazing, and really, really thank you and everyone for taking part today. Thank you.